So take a 2 minutes. So she will give us a presentation on
Connect करो
cornerstone part of autobubble
connect
syndrome
करो
of increased frequency and anomalies in kinetic coordination.
It's not visible. Okay. Yes. Good afternoon, everyone. Good afternoon, everyone. I am Dr. Josna. I am thankful to my mentor guide, Dr. Prasant Acharya sir, for giving me this opportunity to share my experience. So, a retrospective data from 2018 to 2023 in my center. So, the brain anomalies is around 24.3% out of total anomalies, whereas the ventriculomegaly and hydrocephalus counts a lot. It is around 30.83%. So, I will be presenting two interesting cases of hydrocephalus, recurrent hydrocephalus. This is the primi gravida 3 referred to me for anomaly scan with a history of recurrent hydrocephalus and previous history of encephalocele and hydrocephalus in the previous baby. And the findings are now the CSP is not visible. CSP is not visible, and there is bilateral severe ventriculomegaly, no fluid in between the layers of septum pellucidum. Parieto-occipital sulcus is not seen. Lateral fissure is not seen, and there is pseudofusion of the both the occipital hemisphere lobes. Suggest I have mentioned everything in my picture is representation, and there is outer echogenic band over here, and there is reduced pericerebral space, jet-shaped kinking of the brainstem. So a provisional diagnosis of Lissencephaly type 2 or acute stenosis was thought, and MRI is suggested. MRI shows grossly dilated bilateral lateral ventricle. Patient is counseled for the amniocentesis, and amniocentesis was done, followed by CMA. CMA shows no deletion or duplication, whereas the WS or whole exome sequencing predicts there is a homozygous nonsense variation on exon 7, exon 5 of ISPD gene. So the final diagnosis of Lissencephaly type 2 Walker-Werber syndrome or cobblestone brain was diagnosed. Both parents are found to be heterozygous for the same gene. As it is an autosomal recessive condition, the counseling was done accordingly regarding 25% chance of recurrence. And the second case is again referred for the ventriculomegaly with a history of recurrent hydrocephalus, but here you see there is dysmorphic face, unilateral microphthalmos with congenital cataract. It was suggestive of something. So here, when I go to the ultrasound, there is all the features of absent corpus callosum, 3 lines, tear-shaped ventricle, ventricles are dilated, upward displacement of the third ventricle. Then these are the normal pictures above and the abnormal below. So there is absent corpus callosum, staghorn type of anterior horn, and along with that, there is hypoplastic cerebellum. Cerebellar hypoplasia. Here you see the cerebellar diameter is only 2.2 centile. So, and there is hypoechoic region seen on the anterior and posterior to the brainstem, around the midbrain and around the cortex. Again, the same provisional of Lissencephaly with absent corpus callosum was done. Patient was counseled. She is not ready for MRI or anything, so decided for TOP. And the post abortus along with the parental was sent, and we found the MOPOMT2 gene, which is in Walker-Werber syndrome or muscular dystrophy pseudoglycanopathy. Patient is counseled and she delivered the next pregnancy a normal baby. It is a type of cobblestone encephalopathy, is a type of over-migration disorder, and it is a cobblestone complex is a syndrome which is an autosomal recessive, and responsible genes are known as alpha dystroglycanopathy genes and POM2. These are the 6 genes mainly responsible, and the conclusion is that pathognomonic signs of WWS you may not find. So all cases of recurrent hydrocephalus need highly dedicated neurosonogram and MRI. Whole exome sequencing rather than targeted sequencing is advisable. But WWS has some characteristic prenatal ultrasound which could lead to molecular diagnosis. These are my references. Thank you all. Thank you all. And I again invite you all to my Odisha and land of Lord Jagan. Thank you.
Thank you, Josaman. Any questions from the judges? We'll move on our next presenter, presenter number 1, Dr. Euler Yuli. She is going to present on the panorama of fetal infantile nervous system malformation or tertiary care experience.
Hello. Good afternoon, everyone. Thank you, Fetal Brain Society, for giving me this opportunity. I am Dr. Inlo Mule. I'm going to present on the topic panorama of fetal central and nervous system abnormalities in our tertiary care center. Prevalence of congenital anomalies that we have known is around 0.14 to 0.16% in live births. In India, prevalence of fetal CNS anomalies has a varied findings from 21 to even up to 402 per 10,000 births. The true magnitude remains unknown. We decided to conduct a study to evaluate the prevalence and the types of fetal central nervous system abnormalities in a tertiary care center in South of India. We collected the data retrospectively for the last 7 years from the hospital digital recording systems as well as the written records. All the pregnant women who underwent scans from 11 weeks to 22 weeks were included. We did transabdominal scan and transvaginal scans when needed. After exclusion, the total number of scans, 11,908 were analyzed, of which total anomalies were found in 180 cases, about 0.7%. Total CNS anomalies were found in 74 cases, accounting to 41%. Most of the cases, about 90%, were detected in the second trimester. All these women had opted for termination of pregnancy. The mean maternal age in our study was 24 years. The mean gestational age was 20 weeks. The earliest age at which anomaly was detected was at 11 weeks, 4 days. Some of the risk factors we came across was folic acid intake consumptions of around 55%, as well as consanguinity, diabetes mellitus, recurrent abortions, history of other congenital anomalies in the family, primary infertility treatment. On seeing the frequency of CNS anomalies, we found that the neural tube defects accounted for the highest percentage at around 62, followed by the ventricular abnormalities at 19, posterior fossa associated abnormalities at 14%, and the midline disorders at around 5%. This were the subgroup analysis. However, the vascular anomalies and the miscellaneous disorders were not detected. 7 cases had postnatal examination after the first trimester termination of pregnancy. This was the finding, gross findings. And all the cases of 67 in number had undergone a postnatal examination after the termination of pregnancy, out of which 6 patients had consented for autopsy. One of them we found was Michael-Gruber syndrome, and rest I have outlined here. We compared our prevalences of CNS anomalies in the last few decades. The literature review showed consistent findings, except for one study here, which we analyzed that it was a quaternary center, which actually could be a referral bias. And this graph shows the proportion of the prevalence of different types of abnormalities. NTT being the most common, we compared the subtypes and found that the neural tube defects, anencephaly was higher compared to the spinal defect and the other abnormalities. The limitation in my study would be the genetic testing correlations, associations, and it was a retrospective study. However, the concluding that our study had an overall prevalence of fetal central nervous system about 62 per 10,000, combining the first and the second trimester. Most commonly, it was the neural tube defects. However, in future, we hope that we will be able to combine more of the factors, history, autopsy, genomics, or phenome space, and find out the true prevalence. Like all of you out there, I have a team here which backs me up, and I want to thank them and thank you all for the attention. Any questions?
Yes, this is interesting, but I wanted to know, since the majority of anomalies were neural tube defects, so how many patients were subjected to a transvaginal scanning in the first trimester?
So the first trimester scan, when we had a doubt, it was only then we did, because most of the anomalies, only 10% of the anomalies was found in the first trimester. So for the confirmation, we definitely did for 10 people, and the rest of the cases, only when there was a confusion. They were usually in the second trimester. So in the second trimester, transabdominal was pretty good findings for the abnormalities.
So which means it was more or less a screening transabdominally, and if you picked up something, then it was probably transvaginal, or was it a lack of time?
That is always there, yeah.
but you get referrals. So it may also be that the late cases were referred late, so did not carry out a transvaginal scan because they were referred already in the second trimester. You know the percentage of these versus the one that were not scanned?
The referral scans?
I mean, how many cases were referred to your attention
yeah.
only in the second trimester, and
Yeah.
how many already in the first trimester, and you did not do a transvaginal?
So, yes, in the second trimester scans, almost around 30% were the referral cases, which was very well seen in transabdominal. These were the cases which were, the most of the cases, 90 to 90% of the cases in the second trimester were also coming for the first time to us. So, in the transabdominal, we
And so
found-
why, I mean, anencephaly should have been obvious also in transabdominal. So that's why you did not carry out a transvaginal, probably. But you should have picked it up earlier. How many anencephaly you have there?
22.
22. And you picked up in the first trimester 5?
Yeah.
Something like that?
Yeah. And then
But if you
rest.
carry out the first trimester scan, it's an obvious anomaly to pick up. So doesn't match so far. Another question I have is I've seen that you terminated one case of leg spot cyst. Why?
Yeah, yeah. Actually, I read back to the data as why was that terminated. It was an old data. There was a confusion between the posterior fossa abnormalities. So exactly the patient was counseled that it might resolve. But when we counsel the patient in our place, they are more inclined towards everything to be normal rather than having even one consequences. Even after counseling, they are not ready for the risk to take if there is even 1% chance that there might be associated or it might increase in the future.
Do not agree anyway.
Any questions? Okay, thank you.
Thank you.
Our next presenter will be Dr. Ridhima Tejwani, and she is going to present on prenatal diagnosis of vein of Galen aneurysm malformations, a single center experience.
Thank you for giving me the opportunity. I will be talking prenatal diagnosis of vein of Galen aneurysmal malformation, a single center experience at my place. No. It is one of the most common cerebral arteriovenous malformations detected prenatally. It represents 30% of the all pediatric vascular malformations. Although it develops in the first early trimester, but it becomes sonographically apparent only mostly in the third trimester. It represents a connection between a primitive choroidal vessel and the median prosencephalic vein of Marboski between the 6th and the 11th week of gestation. The abnormal shunt prevents involution of the embryonic vein with subsequent development of the malformation. The aim was to evaluate the antenatal associations, postnatal prognosis, and outcome of the VGM. A detailed evaluation by grayscale ultrasound and color Doppler was done in all the cases. The axial section showed a tubular anechoic structure located superior to the thalami, and it was continuous with the dilated sagittal sinus. Sometimes it's called as a comet tail sign. The sagittal section also showed the same thing, but behind the corpus callosum and the cavum CSP. And the color Doppler is the main hinge for the diagnosis, which shows a high velocity turbulent flow within the lesion. Fetal echocardiography and neurosonogram were performed in all the cases, and MRI was offered in all the cases antenatally. Close monitoring of the size of the VGM and the evolving signs of the cardiac failure and fetal anemia were also monitored in all cases. Ultrasound and MRI reports were reviewed and outcome was known in all our cases. Between January 2017 and December 22, 5 cases of VGM were diagnosed, out of which 40%, 2 were intrauterine fetal death, 1 was NNB, and 1 was 2 were term live births. All the cases were diagnosed post 30 weeks of gestation. MRI antenatally was done in 3 of the cases, and both the live births have confirmed diagnosis after the postnatal MRI. Embolization was required in 30 days after birth in 1 of the live births. Cardiomegaly was present in 1 of the 5 cases. Tricuspid regurgitation was present in 2, and none of the cases had ventriculomegaly or any associated brain abnormality noted antenatally. Straight sagittal dilatation was noted in 4 cases. The volume of the lesion ranged from 13 ml to 90 ml. The first baby was stable when he was born, and on the day 9 showed signs of cardiac failure and was admitted for medical management. Transarterial embolization was done on the 15th day. Baby is 1 year old and with normal developmental outcome. The second baby is 6 years old now, and at 3, she was stable at birth and was followed up with MRI every 6 months. At 3 years, there was an increase in the size of lesion, and she had 1 episode of convulsion. So elective embolization was done at that time. Now baby is 6 years with normal developmental milestones, along with detailed 2D ultrasound with color Doppler. Recommendation is to do fetal neurosonography to exclude secondary brain lesions, fetal echocardiography to detect early signs of any cardiac compromise, and fetal brain MRI to diagnose recent necrotic lesions. Follow-up scans should be done every week, and delivery should be arranged in a tertiary scan center. Modern endovascular techniques in conjunction with specialized perinatal intensive care management have enabled VGM to become potentially curable, with several affected babies achieving normal outcome. Feasibility of fetal interventions for antenatal management is also being explored. Thank you.
Yes.
You have reported 2 cases of intra-IUDs, I guess, I think, and that's 40%. So what was the reason of the IUDs? Or
The one case, the patient has not, both the cases actually the patient did not follow up for the scans with us, but in the scan there was, in one case the patient had tricuspid regurgitation, so which is known to be having a poor outcome or unexplained IUD.
there were some other features, pericardial effusions? And
No, not in both.
I would ask the same question because from the table, there were neither cardiomegaly nor TR in the 2 cases. You said that 1 had TR, but if I could follow through,
Yes.
it says that the table said that none had TR as well. But so no overt sign of hydrops.
None.
And if that's the case, how these 2 cases died? I mean, how much time before death of the fetus were these scanned?
Sir, they had scans with us at 30 weeks, both of them, and one had IUD at 31 weeks and one had at 32 weeks.
So it's quite unusual because if you not have hydrops, why should they die?
But they have not followed up with us, so really, they didn't come back for scans, which is,
They just told you on the phone that the baby had died.
yes, when we do telephonic conversation, like outcome collections.
Can it be? Can it be that they carried out termination of pregnancy unofficially?
I
Because
don't know.
otherwise there is no. I mean,
I don't know, sir, but that's what they have told, that it was a baby died inside. That's what they tell when they tell on the.
okay, thanks.
so I guess, was there any checklist which you look at once you diagnose VGM? What else to look for in case of, to prevent
That's
this
what we
kind of?
usually refer to Sir's paper, Palladini Sir's paper, that same flow chart is there and the table is there with cardiomegaly, TR.
So 3 out of your 5 cases, you did the MRI, right? The MRI was done in 3 out of 5. Is it? Anything additional on the MRI? In those 3 cases, it
No,
opted
no.
for the
So
MRI.
one of the cases we had suspected there might be polymicrogyria, but the MRI told it's not there. Nothing additional, no features.
And I think the feasibility of prenatal intervention has been shown very clearly in from Boston data and from
Yeah,
Professor
from Boston and
Neesville
one.
data. So
Yes.
it's not a question of feasibility, but we're still unsure of the long-term
Yeah,
outcomes.
but the Boston people, I think, have done only 2 or 3 cases till.
Yeah, the baby is 3 months old now. So, like as she was saying, at 27 weeks, baby had that REDF on umbilical artery. It was progressing. From AEDF, it progressed to REDF in just a matter of 1 day. So we had to take a decision. We got the data from Boston that they had done the antenatal intervention. So interventional radiologist and myself, we blocked the outflow track, and baby did survive till 32 weeks, 33 weeks. Yeah. Then it started developing increased umbilical resistance again. And then we delivered by cesarean section. Baby was stable for 2-3 days, and again it went into failure. So, but then it stabilized. And after 2 months, again presented with a cardiac failure, but again spontaneously stabilized. And it is now 3 months old. And we are just following up the baby as to outcome. In Boston, they have done just 1 case so far, I think. This would be the probably second case, which
So
we
you
are
did a
planning.
coil? Was it a coil that was done?
No,
A coil
we
embolization?
wanted to do the coil, but it was costing really, it was quite expensive. It was about 4 lakh INR. So we could not afford that. Even the institution could not afford that. So we did the glue agglutination, which was the next best option, which is not an ideal thing to do.
Yeah, there were 2 done at Necker Hospital, as far as I know, with successfully cured baby. And I'm surprised by the use of glue on the spot without any previous, you know.
No, but what has the reversal of flow in the umbilical artery got to do with the vein of Galen?
But forgive me, the glue should have put from the feeders. From the feeders. No, I mean, the coil you put into the ampulla of the Galen. Yeah, but the glue should go to the feeder artery, not into the only in the ampulla. Yeah, so why, how can you use the glue which will come out the moment you put it?
No, but it still flows out. No, it still flows out. The glue has to go distally, not proximally.
That we made us think about 2-3 days whether to go or not.
Thank you. Our next presenter will be Dr. Mamta Agogda. She will going to present on combined structural and functional score for prenatal sonographic assessment of fetuses with CNS anomalies and its correlation with early postnatal neurological outcome. A prospective cohort study.
Yeah. As we know that assessment of the neurological function in the fetal life is a difficult task and cannot be easily done as we do in the neonates. So in this study, our aim was to apply this kind of a combined structure as well as the functional score to see the neurological status of the fetuses presenting with CNS anomalies and correlate it with immediate postnatal survival as well as the early neurological development at 3 months of age. So we've included CNS anomalies presenting at or after 20 weeks of gestation, and we observed the fetuses for about 30 or more minutes to see the functional components. These were the scoring system that we had used. So we had a lot of structural components as well as the functional components. And postnatally, we applied Hammersmith score to see the fetal neurological development. And we use the statistical analysis of correlation and ROC curve to deduce the cutoffs for significance. These are some of the images of the fetuses which we have studied. And just to give an idea of the functional components that we have assessed. So we assess for the fetal movements and the hand movements, the leg movements, and facial expressions such as grimace and smiling, protruding of the tongue, the swallowing reflex, etc. And we scored it accordingly. So some of the expressions that fetuses gave us were this. It was really beautiful to watch. It has a music, but it's not playing. I'm sorry. It's had a funny music. So the swallowing reflex, and here the projection of the tongue and the yawning. So eye opening, etc. So for the results, 43 cases could be included, and this is the distribution of the cases. So we had a variety of anomalies, and Hines score could be applied in 28 cases, which could survive to 3 to 6 months. And this is the overall outcome of the pregnancy. And for the association, we divided into total score that we obtained, the structural score and the functional score, and correlated with the immediate survival outcomes such as ABGAR at 1 minute, 5 minutes, and survival at 6 months. We found a significant association between the scoring system and the immediate survival. However, for the association between the score and the Hines score, that is assessment at 3 months of gestation, 3 months of postnatal life. So in this, we found that for non-ambulatory CP, we had, if the score was more than 40 Hines score, that correlated well with our antenatal score. And for predicting the CP as well as the optimal neurological development, the score was correlating well. And while analyzing it separately, so when we did the combined scoring and the correlation, it correlated well with the immediate survival as well as the neurological outcome at 3 months. However, and we got a cutoff of 13 for that. And structural core also correlated very well with the immediate outcome as well as the neurological development. But however, the functional score alone did not correlate well. So these are ROC curves and the scatter plots that we had. So this study was an attempt to apply a scoring system prenatally to predict the outcome. And we assessed a variety of CNS anomalies, which is both a strength and limitation, because maybe uniformity in the anomalies could be a better idea to assess these application of these scoring system. And it is an ultrasound based study, which is also an advantage because it can be applied widely. So functional assessment, the drawback is it's time consuming. Quality of movements may be more important than mere presence or absence. That's what we felt. And a larger sample size with stratification of anomalies according to severity may be a better way of doing the study. This is a comparison with different studies that are with a similar objective. And I think this study was presented yesterday where MRI-based structural scoring was used in agenesis of corpus callosum. So to conclude, combined scoring correlates with the postnatal neurological outcomes and could guide the clinicians in prognostication and counseling the parents. Structural components have more weightage as of now, and more studies on prenatal assessment of neurological function may be needed before it can be applied for prognostication of neurological development. These are my references. Thank you.
There are two questions on this. In your study, which category of CNS malformations had the worst prognosis, the worst outcome, and the best? And second point is, have you been following it up after 6 months?
We intended to follow after 6 months, but we could not because they go on to the pediatric neurology side. It's difficult for us to track them down, but maybe as a further component of the study, we would like to do that.
Because I think
Yes,
it's learning abilities and
Exactly.
behavioral.
Yes, sir.
So
Yes,
6
sir.
months is a very short
Yes.
time.
This study we concluded only in 2022, so we would like to follow it up.
I have two questions on this table. The first one is you, in the first group, you mentioned 10 cases of open spina bifida with
Yes, sir.
myomelingocele. And then separately, you put 6 cases of carry-to malformation.
Yes, sir. Yes.
So why so?
So, yeah. So we thought we will not include the cases which we will separate out the cases which neural tube anomalies which also had intracranial changes. So that way, like Arnold-Chiari with neural tube defect, we separated out.
But by default, by definition, if you have an open spinal defect, you have carry-two malformation with less than 1% of cases which do not show it in utero. So that's a match.
Probably we'll have to.
And the second question also is all the groups of ventriculomegaly, these are not diagnoses. These
Yes,
are
sir.
signs.
These
So
are signs.
you
Yes.
cannot use that as a classification of
Anomaly.
disease,
Yes.
because otherwise you may have mild ventriculomegaly with L1 syndrome on one side and severe ventriculomegaly with aqueduct stenosis. I will be on wrong side of the prognosis. So doesn't make sense to me.
Yeah, we didn't look into the cause of the underlying defect. We just wanted to apply it as to see whether this correlates with the neurological outcome. Probably that is why we have put it as a limitation, that we had wide variety of things that we included, because we did it as an experimental.
It's a very major limitation because the inclusion is so broad.
Yes.
You cannot bracket mild ventriculomegaly
Exactly.
and a malformation of cortical development in the same
Yeah.
bracket. Then say
Moreover,
the
the
function is
sample size, getting the sample size for the same kind of anomaly is difficult for a single center. It needs a multi institutional collaboration, because these anomalies as such are rare.
So this is not
yes.
like saying ACC has this functional score or structural score. When you say mild ventriculomegaly and the malformation of cortical development in the same bracket,
Exactly.
the applicability, the clinical applicability of the score becomes very
Yeah,
low.
that is why we put
And,
it as a limitation. That,
and also when you say functional assessment, isn't just the motor function that you've looked at.
no, even the kind of the expressions that the babies were giving, which are finer things, they were looked into.
It's again motor function, isn't it?
Yeah. You cannot, what kind of sensory function?
It's not like saying in a lumbosacral meningocele you have a functional
The-
deficit.
like
So you cannot.
evacuation of the bladder, those kind of things.
No. I'm saying with the malformation of cortical development, or say, for example, L1-CAM syndrome, you cannot look at the motor function and say this baby's functional outcome is going to be good. And that's probably why your functional correlation.
Probably, yeah,
was very
probably.
poor.
That is why we have put it as a, like, we recognized it as a limitation, but we wanted to do it as an experimental thing, whether these functional things can have any correlation with. Thank you.
Going to present on prenatal diagnosis of central nervous system abnormalities, USG, MRI, autopsy correlation. Dr. Neha.
Good afternoon, everyone. I'm Dr. Neha Mahindru, and I will be presenting a study on prenatal diagnosis of brain abnormalities, ultrasound, MRI, and autopsy correlation. So as we all know, the diagnostic performance of expert neurosonography is about 80 to 90%, and fetal MRI is used as an adjunct tool to ultrasound for either confirming the ultrasound findings or as a search for additional CNS abnormalities that may change the prognosis and further counseling. Literature states that the clinically relevant yield of MRI over expert neurosonography ranges from 7 to 40%. So the aims of our study was to compare the accuracy of expert antenatal neurosonography and prenatal MRI in the assessment of brain anomalies, taking perinatal pathology as the gold standard, and to determine the potential advantages and fallacies of neurosonography and fetal CNS. So this was a retrospective study over 12 years in a tertiary center in southern India. The neurosonogram and perinatal pathology was done in our unit, and MRI was done with a senior radiologist. The inclusion criteria was cases with neurosonography, MRI, and perinatal pathology available. Coming to the results, out of all the CNS abnormalities, 480 cases were offered MRI. Out of these cases, 36 had a neurosonography, a prenatal MRI, and perinatal pathology examination. Out of the 36 cases, 9 had an autolyzed or disintegrated brain, and 27 cases were there for study. The most common indication for referral for an MRI after a neurosonography was to confirm the ultrasound diagnosis, that is in 47% of cases, and search for possible additional brain anomalies. Now, the most common frequency of the CNS anomalies with neurosonogram diagnosis for which MRI was done was in 33% of cases for midline abnormalities. and 20% for malformations of cortical development, 14% for abnormalities of the cerebellum, 11% for ventriculomegaly, hemorrhagic lesions, and others. So here we note that in 63% of the cases, that is 7 out of 27, there was a match between the neurosonogram and MRI. However, we note in 19% of the cases, there was mismatch, that is MRI provided additional clinically relevant information. Out of the 3 cases of the 27 cases, that is 11%, neurosonography was more accurate than MRI. And in 2 cases, MRI and neurosonography had a similar diagnosis. However, autopsy had a different conclusion. So these are the 5 cases in which MRI provided additional information. First is at 34 weeks, a solid mass seen in the left cerebral hemisphere, and on MRI, it was intracranial hemorrhage grade 3. That was diagnosed on autopsy as well. Second was agenesis of corpus callosum with megacisterna magna. On MRI, it was Vermean hypoplasia with reduced volume of bilateral lobes. Third was a narrow CSP. MRI was dysgenesis of corpus callosum with lesion cephaly. Fourth was brachycephaly with CSP difficult. MRI was lobar holoprosencephaly. And last was unilateral cerebellar hypoplasia. Additional diagnosis was cortical abnormalities of the cerebellar hemispheres. These 3 cases in which neurosonogram was more accurate is in cases of abnormal CSP, in which there was partial agenesis of corpus callosum. However, on MRI, CC was given normal. Second was altered shape of calvarium, acrocephaly on autopsy. Third was Blake spout cyst, inferior Vermean hypoplasia on MRI, which was Blake spout cyst on autopsy. These 2 cases are in which autopsy had a different conclusion. So it was septal agenesis on both imaging modalities. However, there was additional diencephalosynapses. And second was bilateral ventriculomegaly. There was additional lesioncephaly. So this bar chart reiterates the findings in which the midline abnormalities, hemorrhage, and abnormalities of the cerebellum had MRI as additional findings. So the limitations of my study was that it is a retrospective series with a small number of cases, which limits drawing a generic conclusion. And a large number of cases had brain autolysis, which emphasizes the fact of brain fixing importance. Concluding, ultrasound is the primary imaging modality, MRI is to complement in certain conditions. And we emphasize that an integrated approach to reporting with MRI and neurosonogram may enable us to overcome limitations and reach to a conclusive diagnosis. MRI is an additional tool, especially in India, where the termination of pregnancy is before 24 weeks. And in cases of termination of pregnancy, perinatal pathology should be opted to provide a conclusive diagnosis to counsel the family. Thank you.
Thank you.
So when you include only those cases that had an autopsy, there's automatically an inclusion bias that comes in.
Yes,
Because
sir,
you're choosing only the really bad abnormalities. And it's surprising that in those bad abnormalities, there was an additional 19% added on information from the MRI. So probably because TVS was not done in all the cases.
That was one limitation because the babies were in persistent breech position, and even in multiple sittings, the baby was not cephalic. But that is one limitation that we did not take postnatal MRI or postnatal autopsy images or conclusion in our study. So that is one limitation of us.
First, I will congratulate with you twice. First, for keeping all the data in 5 minutes, which is a miracle, I think.
Thank you, sir.
And second, because it does replicate what is, we published several years ago a large paper on my stay in Naples on 800 cases. And we roughly have the same, if you put all the data together,
yes.
Because the 19% of additional value of MRI is false because you miss 3 or 4 of the cases that you could have done with neurosono, with transvaginal neurosono. So at the end, if you detract from the 19%, 11% that only MRI on neurosono, you were right. And the false negative at neurosono, which probably was due to the experience of the operator or the fact that there was a breach and so you carried out a transabdominal ultrasound, then you reduce the yield of MRI to below 10%, which is what both Gustavo's group and ourselves are showing as a real additional value if you carry out a transvaginal scan. So congratulations for the data.
Thank you.
Thank you. Our next presenter will be Dr. Komal Rangolia. She's going to present on ventriculomegaly in association with the CNS anomalies. Can ventriculomegaly in CNS anomaly be compared with the excess deviation in the cardiac anomaly or retrospective study? And the second presentation will be on a CNS structural anomalies and genetic association by her only.
Ventriculomegaly is an enlargement of lateral cerebral ventricle caused by an excess of CSF. Fetal ventriculomegaly is defined as a ventricular atrium which measures 10 mm or greater at any gestation. Incidence ranges from 0.3 to 1.5% live birth. Unilateral ventriculomegaly occur in 60% of cases, while bilateral in 40% of cases. Ventriculomegaly may result from obstructive malformation, destructive lesion, and abnormal development of the brain. In mild ventriculomegaly, structural anomaly ranges from 10 to 76%. However, in apparently isolated ventriculomegaly, malformation are found in 30% of the cases after birth. Chromosomal anomaly are detected in more than 50% of the cases when ventriculomegaly is associated with other fetal anomalies. This retrospective study of all cases of CNS anomaly presenting in tertiary fetal medicine center in previous 5 years. Ultrasound scanning for all selected cases were performed using Volusion E10 machine and probe. All cases of CNS anomaly with or without ventriculomegaly with gestational age more than 14 weeks were selected. All cases of open neural tube defect were excluded from the study. The cases are categorized based on the size of the lateral ventricle and the type of CNS anomaly. All ventricular measurements were obtained with transabdominal ultrasound probe using ISOP guideline. Both lateral ventricle were measured in order to characterize unilateral and bilateral dilatation as well as the symmetry between the ventricles. We use up to 7 mm as a normal ventricle, 7 to 10 prominent ventricle, 10 to 15 mild ventriculomegaly, and more than 15 as a severe ventriculomegaly. Over the period of 5 years, total 8 to 2 to 4 pregnant women were screened. 240 CNS anomaly, that is a 2.9% as the incidence of CNS anomaly. 59 cases having open neural tube defect were excluded from the study. Out of 181 cases of CNS anomaly, 165 cases fulfill the inclusion criteria were included in the study. This table shows the distribution of cases with CNS anomaly based on the size of the ventricle. 34% is having the normal size of ventricle, 24% having prominent ventricle, 35% is ventriculomegaly, while a 5% in which the size of ventricle is not measurable due to the monoventricle in holoprosencephaly and the gestation age is less than 16 weeks. This table shows the ventriculomegaly and association with the CNS anomaly. Most common CNS anomaly is the SEC, TSEC, followed by cystic lesion of brain, Dandy-Walker malformation, hypoplastic cerebellum, and holoprosencephaly. This table shows CNS anomaly associated with normal ventricle. In total, 28 cases of PSEC, 13 cases have a normal size of ventricle, that is 46%. In Dandy-Walker malformation, 47%, megacystoma magna 50%, in BPC 80%, lipoma in skull, rhombencephalocyanopsis in vein of Galen malformation, almost 100% cases have a normal size of ventricle. This table shows the postnatal follow-up of isolated prominent ventricle and isolated ventriculomegaly shows the rate of termination of pregnancy is very high in severe ventriculomegaly. So ventriculomegaly predicting CNS anomaly, the sensitivity is 43%, specificity is 73%, positive predictive value 74%, negative predictive value is 41%. Excluding the cases of isolated prominent ventricle and ventriculomegaly, there were a total 185 anomaly, out of which 12 anomaly had a non-measurable ventricle. Out of remaining 173 anomaly, 10 had a normal and prominent ventricle and only 64 cases of ventriculomegaly, that is 34%. 34% cases of CNS anomaly and the 34.5% of CNS anomaly had a normal size of ventricle. Positive predictive value of ventriculomegaly predicting the CNS anomaly 74%, negative predictive value is 41%. Sensitivity of ventriculomegaly detecting CNS anomaly is 43% and specificity is 73%. Positive predictive value of abnormal axis in cardiac anomaly is very high. From our study, we can conclude that ventriculomegaly does not predict the presence of structural CNS abnormality, nor a normal size ventricle rule out the presence of structural CNS anomaly. A detailed and thorough evaluation of the fetal brain is necessary, even in the presence of the normal size lateral ventricle, so as to avoid missing out any CNS anomaly.
If I can ask. Okay. I just wanted, I was wondering why a category of 7 to 10 millimeters of the ventricle size has been categorized as prominent ventricle and the normal ventricle is separate. So don't you think 10 millimeters is,
Sir, in 7 to 10 millimeter size ventricle, we alert and we do the neurosonogram in every patient. So we consider 7 to 10 as a prominent ventricle and do a neurosonogram in every patient to rule out.
That's not the way to go, sorry, because otherwise you carry out an examination on 30% of the population. So guidelines are there and papers are there, so you should not go off astray from what is clinical medicine. You should stick with current knowledge, not go on your own. So this is the first issue. The second issue, in the conclusion, you mentioned the cardiac axis, which I think it's a typo from a previous publication that you were not even aware of mentioning. What is the cardiac axis? Does it match with this your presentation? Why did you have a line in cardiac axis? Are you aware of that?
You can go back to your conclusion.
Go back to your conclusion, the last slide.
I think she's trying to compare ventriculomegaly as a sign that can stimulate you to look further, like the cardiac axis. When the cardiac axis prompts you to look at cardiac anomalies, the pickup rate of cardiac anomalies is high when you look at the cardiac axis. The axis is deviated. Is that what you're trying to say? Yeah. But I think you cannot compare apples and oranges.
It's a long jump, very long jump. Okay, thank you.
Please move on to your next presentation.
Structural anomaly of central nervous system are one of the most common fetal anomaly found during prenatal imaging. USG is the most important modality for evaluating fetal CNS anomaly defect. Prenatal diagnosis of CNS anomaly remains challenging due to the ongoing growth and fetal brain development. Genomic variation are important etiology for fetal anomalies. Karyotyping and chromosomal microanalysis are effective at diagnosing chromosomal anomaly and copy number variation. In our clinical practice, whole exome sequencing is usually applied after uninformative CMA result to detect single gene mutation. This strategy is economic and effective also. This retrospective study was performed in Department of Fetal Medicine previous 1 year. Out of total 5548 patients, 4 fetus with CNS anomaly detected by USG were included in our cohort. 19 cases were received invasive prenatal diagnosis by amniocentesis and chordosynthesis. Although fetus was first analyzed by the CMA and all CMA negative cases were offered whole exome sequencing. Few cases were subjected to the torch, PCR and FISH panel depending on the tentative diagnosis. All cases were divided into two groups, isolated and non-isolated CNS anomaly. There were total 114 CNS anomaly. The neural tube defect was the most common CNS anomaly, that is 40%, followed by ventriculomegaly, that is 27%, holoprosencephaly 9%, followed by ACC, Dandy-Walker malformation, and Vermeer hypoplasia. Extra CNS anomaly include gastroschisis, omphalocele, cleft lip, cleft palate, micropnea, cardiac anomaly, and skeletal anomaly. This table shows the total number of patients of specific CNS anomaly and among which how many is undergoing the invasive testing. In ACC, almost 100% positive genetic rate. In Dandy-Walker malformation, almost 50%. In Vermeer hypoplasia, also 50%. In holoprosencephaly, 100% positive detection rate. In microcephaly, also 100% detective rate. Out of 19 cases, 26 had an abnormal microarray. 36 cases had a normal microarray report who were subjected to the whole exome sequencing, out of which 28% had an abnormal whole exome sequencing. 15% were directly subjected to the whole exome sequencing and all 3 were abnormal. 3 out of 19 cases had a FISH panel report, out of which 1 had an abnormal report, that is trisomy 21. 1 case was positive for the cytomegalovirus. In result, microarray report include 2 cases of trisomy 21, 1 case of trisomy 13, 1 case of trisomy 18, and deletion 11, 1 case of the deletion in 11 chromosome. FISH panel report 1 case of trisomy 21, 1 case of cytomegalovirus positive. In whole exome sequencing report, 3 case was pathogenic variation and 2 case of the variant of unknown significant was found. Case 1, ACC, which is positive for the trisomy 21. Case 2, Vermeer hypoplasia symmetrical, severe asymmetrical early IUGR, which is positive for the trisomy 21. Case 3, Dandy-Walker malformation, which is positive for trisomy 21. Case 4, PACC plus omphalocele and gastroschisis, positive for the trisomy 18. Case ACC and median CLCP positive for trisomy 13. Isolated case of ACC which is for positive for deletion in 11 chromosome. Case of microcephaly, absent corpus callosum poor sulcation which is positive for the cytomegalovirus. Severe ventriculomegaly with inferior vermian hypoplasia with eye changes which is positive for the Walker-Warburg syndrome. Mild ventriculomegaly at 26 weeks. Previous pregnancy was terminated due to the ventriculomegaly, and this pregnancy whole exome report shows the likely pathogenic Barrester-Winter syndrome. Lobar holopresent cephaly with extra CNS anomaly, which whole exome report shows the VUS uncertain significance. Echogenic CSP with thick dysplastic CC with ventriculomegaly, in which the microarray report was negative and whole exome sequence reporting shows the likely pathogenic, that is for the hydrocephalus. Syntalent cephaly and SEC at 34 weeks, in which the whole exome report shows the uncertain significance. Conclusion, prenatal testing microarray and whole exome sequencing. If microarray is negative, significantly improve the identification of genetic disorder in fetus with CNS anomaly, regardless of whether the fetal anomaly is isolated or not. And it can significantly impact parent decision making for current pregnancy and counseling for the future pregnancy.
Thank you so much, Dr. Komal.
We'll
Why was the CMV infection case included when you were doing a study on genetic correlation of structural abnormalities? You knew can you tell us more about CMV case? And
in this case, whole exome report also simultaneously we sent, and which was negative.
Okay, so you didn't suspect CMV before you?
Yes.
So we'll quickly move on to the next section. The next section is going to be a consultation simulation for clinical cases. It will be a panel moderated by Dr. B.S. Ramamurthy sir and Dr. Chandarulla sir, if we can please have you on stage. And the participants would be Professor Dario Palladini, Dr. Lokesh Lingappa. Dr. Lokesh Lingappa is a pediatric neurologist practicing in Hyderabad. We have Professor Daniela Pryor with us. She'll be joining the panel. Dr. Vivek Krishnan will be joining the panel. He is an obstetrician and a fetal medicine specialist practicing in New Delhi. We have Professor Andrea Regini. Sorry. My sincere apologies. Sorry. We know Dr. Vivek Krishnan and Dr. Vivek Kashyap. Sorry, apologize for that. And Dr. Andrea Regini, please. And we have some interesting cases for the panel, I'm sure.
Yep. So this is indeed a case that we are trying to come to grips with, because I think it's the one of its kind, and I'd just like to put up this case for discussion and solicit your opinions, inputs, your experiences. Now, here's a 28-year-old lady. There's no significant history in terms of pointing a direction. She came to us at 19 weeks, and I'm showing you the transventricular section at 19 weeks. I solicit your opinion. We have all our esteemed panelists over here. Anybody can pick up this question. I've just picked up this case about half an hour ago, and I haven't made a set of questions, to be frank with you. And this question goes A, B, C, no, not really. Okay, Dr. Vivek Kashyap, can you just interpret this transfer section for us?
See here, okay, we can see the ventricular size appears to be normal on the eyeballing. And we can see the choroid plexus, we can see the distal hemisphere clearly. We can't see the proximal hemisphere so very nicely, but then I would like to evaluate or maybe look forward to a cine loop where we can see the proximal hemisphere. I am not able to see the corpus callosum nicely on the sagittal section.
No,
Plus the
no,
cavum
no,
septum.
no.
Okay,
Yeah,
sorry.
you go.
The cavum septum lucidum appears to be not really that typical, the shape that we generally see. And then this is 19 weeks. Oh my God. So it's absolutely abnormal. So CSP is abnormal. The first thing gone, CSP. So now I
Abnormal?
would like to, yeah.
Abnormal. I mean, these are pictures which I have pulled out of the archives after we knew that there was an abnormality. So these were not pictures made with the knowledge that there's going to be a colossal abnormality. These are retrospective pictures pulled out once we knew there was something abnormal as late as 29 weeks. I'll take you to those slides. Given the fact that it was done as a routine mid-trimester anomaly scan, would you want to review what you said as regards the CSP, Dr. Vivek Kashyap?
I would definitely.
19 weeks CSP.
Well, I would like to wait a while.
Wait a while.
No, but 19 weeks, normally we do see a CSP at 19 weeks.
The
There's no-
CSP is seen, huh? CSP
Okay.
is indeed seen. Vivek Krishnan, what about you? CSP?
That would pass off as normal, sir. in my
You would
book.
pass off? Okay, for 19 weeks, I agree, Dr. Kashyap feels that the CSP could be more brilliant, so on and so forth. But given the fact it's 19 weeks, I would say this is normal, and that's how this case went on. And this is the nasal bone picture that we've documented to show you. I mean, this is really not for corpus callosum because we had no clue as what's going to really burst out in front of us later on. But in this nasal bone, again, Dr. Vivek Kashyap, do you see the corpus callosum at all? Accidentally, this is not a corpus callosum picture, not at all.
No, we can't.
Bit of the corpus callosum seen or not?
No.
Okay, the vermis is seen. We know
Yes.
this is through midline, and I can see a bit of the corpus callosum. Just to tell you that yes, transabdominal is not the great way to see a corpus callosum if you're not using a high frequency transducer and the lady is not an ultrasound friendly subject. This baby also had a CTEV, and that's about all we found at 19 weeks. And we said we offered them an invasive diagnosis. The fish ruled out trisomy 21, and there were no copy number variants in the chromosomal microarray. So she was counseled, CTEV, counseled, sent to the orthopedic surgeon, went away, and she came to us at 29 weeks for a growth scan. And at 29 weeks, this is a transventricular scan again. The whole panel, your opinion, please. Anything really out of the way?
I'm not very happy with the anterior complex.
You're not happy with the anterior complex?
Yes.
How many of my other panelists agree that the anterior complex is abnormal?
Also posterior.
Pardon me?
Also posterior complex, as you say.
This is not done for the
I mean, the
posterior.
CC looks really strange.
Yeah.
In the sagittal.
You feel that the CSP looks normal?
I mean,
It's a
the
little-
corpus callosum is something strange from the beginning.
No, I'm not talking of the latter picture. I'm just talking of the transventricular section.
CSP looks a little shortened for me.
Yes.
A little shortened you feel, fine, okay. Now, we didn't feel so really when we did, actually this is Rachita's case, but when she got into the facial profile, something made her sit up. This is the nasal bone, that's the profile. You see the vermis here, transabdominal.
Sure.
Your opinion, please, Dr.
Sure.
Dario, Madam Daniela.
In this graphic or carcinogenesis, and I will also explore the area in front of the anterior and superior to the corpus callosum.
Okay, so area anterior and superior to corpus callosum. But then what, do you feel that the corpus callosum is kind of getting truncated over here and not flowing through?
Yes.
Not flowing through. So that's exactly what perhaps Rachita saw. So we did a little more targeted scan. You just had to move the transducer. We didn't have a transvaginal access, and all these are transabdominal pictures. If you've used your transducer and if it's a fairly high frequency transducer, you can almost mimic what you can get on a transvaginal scan using an abdominal route. Now here is a mid-sagittal section at 29 weeks, and our heart sank.
Very short.
A simple question, corpus callosum normal, abnormal. If it's abnormal, what is the abnormality?
It's very short.
No, there is an indentation, and I would wait a few weeks to look for lipoma.
Okay, so there is an indentation, which means that you're implying that there is an anterior component, there's a posterior
Posterior.
component. And at the indentation, what do you feel is the thickness of the corpus callosum?
So can we see for any vessels here?
For any vessels there?
Yes.
I've not pasted the colored off the
Corona.
pictures,
Corona.
but there's another
Is there a
finding here.
sulcus that goes radiation?
Excellent, excellent. You can
So-
see at the exact point which Dr. Palladini, Dr. Dario picked up, that indentation, you have as it were a radial sulcus which is pointing exactly to the site of the indentation or narrowing. And that was an eye opener. Okay, one question.
Dr. Ramamurthy. Yeah, that's exactly what Dr. Simon, he is also still online. So he has sent a message. Is it not a great idea to make a call on a single static image? I would ask for a cine sweep in axial, sagittal, and coronal sweep, and then we will discuss.
I've got a mid-sagittal section.
This is what, yeah, this is a message from
problem.
Dr. Simon
No
now.
problem.
So,
We are already
thank
past
you,
that.
thank
We're
you,
in the
thank you.
corpus callosum. Also, so there is a pointer to it there, and that tells us what? What is the message that this radially oriented sulcus telling us?
If that would be an MRI, I would suspect a midline interhemispheric fusion of a holoprosencephaly. But of course, I'm not used to look at ultrasound images.
Okay, that's a good idea because a middle hemispheric variant, a very subtle form of a middle hemispheric variant across the parietal lobes, that may be in question. But
Could you go back to the 19 sagittal, 19-week sagittal, please?
sagittal of the previous,
Yeah, if it's possible.
you
Otherwise,
sure? Is that the one?
yeah, that's one.
Yeah.
No, the 19-week, 19-week.
19 week. Yeah,
Okay.
okay, so we are left with this finding, a sulcus which is pointing out, and there's the mid segment of the corpus callosum really looks normally thin. Now is you've got a CMA which is negative, you've ruled out a copy number variant. You might have some DNA left in the lab, but what are we going to tell this patient? And also the fact that you have this cingulate sulcus which is interrupted, and perhaps there's resumption a little, you might imagine a little resumption of the cingulate sulcus there. So clearly this has a strong messaging. It says this is not an acquired insult. This is not due to an ischemic insult. This is due to a developmental abnormality. Am I thinking on the right lines, the panelists?
But doesn't it go against the bidirectional theory of callosal genesis?
We'll come to that a little later, Vivek. The question is this finding of a sulcus pointing to the site of thinning, can it help me to say it's developmental versus neurodestructive or clastic or an ischemic insult?
Development.
Does an ischemic insult to the corpus callosum lead to an interruption of the cingulate sulcus and a radial sulcus formation? Simple. Unlikely. Dr. Manikandan says unlikely. So I think it is developmental. And then you sit up, and as Dr. Vivek Krishnan says, you'll have to look at developmental. Can you tell us what you have in mind when you say development?
So when you say it's a focal segmental agenesis, the corpus callosum starts developing in the body and then goes anterior and posterior. It's a bidirectional theory that all of us have heard about. So with the segmental agenesis, and how is the rest of the corpus callosum formed? Behind the sulcation that you're saying.
Okay, so that brings us to the basic. I'm very happy you thought of development and embryology. So we'll presently go and look at revisit embryology very quickly. and refresh our minds and see where we can fit this lesion. We'll just go back to these slides here. And this is the classical landmark paper of Dr. Charles Prebo in the Neuroradiology Journal, done about 14 years ago. And he described the corpus callosum as coming from the lamina terminalis, which actually thickens out dorsally to form lamina reunions, and the rest of it is lamina terminalis. And to cut a long story short, he speaks of a posterior callosum coming from, so being associated with the hippocampal commissure, and you have a glial sling dependent anterior callosum, which is coming up from the anterior commissure related, right? So clearly two segments, an anterior segment and a posterior segment. That is the anterior segment, that is the posterior anterior segment, posterior segment. And he says that the two components fuse at the isthmus at the level of the hippocampal commissure by about 15 weeks. We can't see the hippocampal commissure by ultrasound, but we know that it's somewhere around the isthmus of the corpus callosum. And we also know the thinnest segment of the corpus callosum is the isthmus. So embryologically, it kind of tallies. And if you believe in this kind of developmental anomaly, can you directly relate it to the findings that we've seen in the index case, the case that we discussed now? Does it make sense? Yes. Right? So I think this is what is known as a segmental callosal agenesis. Let me go back to the case, and I have a couple of slides to show you, and then we'll take the final comments before I get Dr. Chandra on the stage. Okay. So again, that's the sulcus there, and it's the interrupted cingulate sulcus that you see here. And of course, go back to literature. You have one case reported in 2010, looking the same, but this was due to Wallerian degeneration in a neonate due to ischemic injury. This was not reported as a developmental, as of being developmental in origin. Then I found this picture in Radiopedia just now, and I thought I'll share it with you, but I don't have any other supporting literature on this except that there is this sulcus which is pointing to the area of thinning. And then, of course, this is a paper by Dr. Maria Savarino, very much from Dr. Dario's place, who did a structural connectivity analysis in children with segmental callosal agenesis. Actually, she found 3 types of segmental callosal agenesis doing her DTIs and looking at the abnormal tract. I can't make out much of this, but these are the 3 types that she described. But we have no clue as to how to actually counsel this patient. So I just want Dr. Lokesh, if this patient were to come with these findings to you, what would be what would you tell them across the desk, across the table?
I think it's very challenging. What in general is the corpus callosum, either complete corpus callosal agenesis or partial corpus callosal agenesis, both almost have a similar outcomes. That is all. So if they can have developmental anomalies. We have in the follow-ups of many children with corpus callosal agenesis incidentally detected because they just had a seizure, and you do a scan and they have a corpus callosal agenesis, they are going to school. But we have children with partial agenesis who are severely affected. So it's a very variable outcome. They have underlying genetic abnormality. So uncertain outcomes, that's what we can say, but a definitive outcome is going to be quite challenging to counsel these families based on the given information, because there are no other associated abnormalities anywhere else in the growth or other structural other organs except for the CT.
Okay, Dr. Lokesh says that he would consider it as a partial callosal agenesis and do a counseling on those lines. I think that's fair enough. We don't, this lady, any other inputs, Dario, Dr. Andrea, Dr. Daniela?
We have Professor
The two
Mar
debates.
and Professor Karina online with us, and they would like to share their thoughts as
Wonderful,
well
wonderful.
on this very interesting case.
Wonderful, wonderful. Please.
Hi, do you hear me?
Yes.
Hi, Rama. Thank you for this very, very interesting case. I have some inputs that I want to share with you guys. First, allow me to disagree with your theory on the development of the corpus. And Roy has published a very, very nice paper showing that from this, from what you have shown in the embryology, the corpus callosum is growing anterior and posteriorly from this beginning that comes from the laminar reunions, which is like the posterior part of the genu and the anterior part of the body, and not growing from two different aspects and joining in the midline. So I believe that this concept that the corpus developed by two parts and then join, it's incorrect, and then could not explain the abnormality that you were showing us. Indeed, I don't believe that imaging is enough for us to state whether a callosal abnormality is developmental or acquired. And I have many proofs of it, because there are some cases in which we've seen this genesis looking as a malformative case, and the pathology proves there is inflammatory and gliosis and other reactions secondary to an insult. We even have some cases of call-for that were proven to be imaginologically just callosal dysgenesis, and then the exome sequencing and the PM showed us that there was an insult. So I really, really think that we should be humble before we state what is the clear nature of the callosal abnormalities, because imaging will not be enough. Maybe the tractography can bring an input to it. And the last thing that I wanted to say, that I agree with Daniela regarding the possibility of interhemispheric variant. The coronal images are very important to help us also to see if there is a lack of cleavage in the midline, and also the position of the Sylvian fissures are important. That another important clue that we can use for the differential diagnosis. But I would be a little aware before stating that it is a developmental abnormality, and insult is a very, very good option as a DD that sometimes we cannot see. So I don't know if you have done exome sequencing in this case, but I think it's a real indication. And regarding the prognosis, I wouldn't call it like partial genesis, as now we have put everything in the same bag, like this genesis. I think the most probably prognostic factor will be the presence of associated findings. But like if it's called for, so we have all the possibilities of call for. So the genetics is also important. Thank you.
Thank you, Karina, for those inputs. So here is a controversy. Yes, it may not be developmental. It could actually be an insult. It could be actually a very subtle segmentation or cleavage disorder in terms of holoprosencephaly of form fruste, if I may use the word. So yes, this is bound to generate certain amount of discussion. And do we have Dr. Simon for his comment? Oh, Dr. Simon, please.
No, I don't have much, Rama, to add to that, other than looking at that sagittal sweep. There was some impression of radial burst appearance more posteriorly. If you go bring up your sagittal sweep. And it would, I don't know, Rama, did you, you don't have an MR on this postnatally, do you?
Nope. This was not, we didn't get a follow-up because they didn't want to continue the pregnancy. In fact, an MR was suggested. No MR. We couldn't get an MR done for her. And they went in for a termination of pregnancy. So
Because
we don't
sometimes
have
when
an
you-
MR picture. I don't.
Yeah. Because looking posteriorly, the cingulate you can't see, and then more posteriorly, there look like radial sulci. Again, something you see with the segmental agenesis. And I agree with the comment that I think probably needs to be separated at something like this and the partial agenesis. But that largest series on partial agenesis includes these segmental defects. And the comments made in these segmental defects that you see that radial burst appearance, but it is very subtle. Bring up your sagittal image and you'll see what I'm talking about.
Yep. Can you see it?
No, I can't.
Oh, you can't. Can this?
Yeah. So if you see there, the cingulate gyrus ends at that point where that radial sulcus comes in. And I think that's probably the thing that would strike me most on this image. You start off thinking that it's a short corpus callosum, and then you see that the cingulate gyrus does not continue posteriorly, and that then I get that impression of radial burst appearance more posteriorly. But what an interesting case, Rama.
Thank you. Thank you, Simon. Thank you. Thank you.
Daniela, maybe you can give us an input of the MR in these cases.
Can I say something?
Please,
This
Dr.
is
Andrea.
This is Andrea Reghini. Can you put up the slides of the people from Genoa, from Gaslini, the paper? I have to say two things.
Just a second.
Well, of course, it's very, very interesting case, very, very interesting field, very unclear field. But to make things simpler, first of all, in this particular case, at 19 weeks on the sagittal ultrasound, the corpus callosum was too short. So at least in our institution, usually they ask for MRI at around 20, 21 weeks because it's something that is really the new ultrasonography doesn't like a picture like that. But more importantly, if you notice also the paper of Genoa, of Gaslini, there are all, you don't have to look at DTI. DTI is misleading because the corpus callosum or some remnants is still there. It's very, very thin, but it's still there. So that means that in order not to have the corpus callosum in there, you must not have the psalterium or the fornix. Which you see the fornix. The fornix are here. You know, you see, I don't know what they wrote in the paper. Don't remember. But when you have this green stuff here, which is the fornix, that means that the fornix is the bed over where, and the psalterium, which is in between the two fornix, the bed where the corpus callosum is developing. I totally agree with Karina when she's saying that is not the theory of two pieces. Posterior piece is challenging because what we miss with imaging is a resolution. I'm pretty sure with higher resolution, with higher DTI resolution, going to be able to see there is some callosal fiber there. Unless you have a real clastic lesion, which must be very dramatic lesion, which is destroying also the fornix and the psalterium. So, or unless you have a real interhemispheric variant or prosencephaly. So, before saying that there is an interruption of the corpus callosum, it must be really, really caution. Even in this case of Genoa, you see in the first images here. The first image is here. The corpus callosum is there. It's totally there. No, it's very thin, but it's there. It doesn't. Don't look at DTI. DTI is completely misleading. You see, high resolution image is there. That means that here you may have also some psalterium. Yes, it's fused. Psalterium and corpus callosum remnants. So it's totally misleading. Probably in this paper they think about two pieces, but it's misleading, in my opinion. Thank you.
Rama, can you go back to the 19-week picture? I want to say a technical, I want to speak about a very important technical aspect that I think is very good for us all, for our sonographers.
You're not going home yet, Rama.
Can you get?
We are not releasing you that fast.
I think next Congress will be only the cases for 5 days, and we can continue by just like that. I think
you can bring only one case; it's enough.
Yeah.
Rama, what I wanted to show, and this is important for us, sometimes it's so hard to get the fetus to the right position. And here you scan, I understand that it's what the fetus gave from the frontal aspect. And we have spoken about the different sagittal views. So in this case, maybe if we could have a transvaginal or even a transabdominal, but an insonation to the central sagittal suture and not the frontal, maybe it would have given a better resolution on this area, because you have 0 degrees with the body and the splenium.
No, Karina, this was a normal CSP to us, and this is
I don't agree.
Section.
I don't agree with you because the angle is not enough to be sure what happens with the splenium if we have a splenium and with the body. So
Dr. Karina, there was no intent to look at the corpus callosum really. That is what I want to say. We didn't.
But why? No, Rama, it's not a critic for the exam you have done. It's a point for us to learn. If we check on the corpus callosum through the frontal horn, through the frontal or the metopic suture, sometimes, like in this picture, we cannot define well the anatomy. And if we want to have a better question, a better answer, we need to insonate it from the sagittal suture and not from the metopic suture. This is not enough information.
Absolutely, we didn't embark on a neurosonogram at all at 19 weeks, and even if we would have called her at 20, 21, or 22 weeks. This is just a retrospective picture that we've taken for nasal bone, and I'm presenting it to you because it's some part of the corpus callosum is seen here, nothing more than that. There was no intent to do a neurosonogram at this stage.
Thank you very
Karina,
much.
thank you for your comments.
Thank you, Karina. Thank you, Karina. We are moving to the next case because already we are now Chandra is going to present his 2 cases, one case on ventriculomegaly and one case on, if time permits, beyond 15 minutes, then we will discuss posterior fossa just like that. What are you going to present first, posterior fossa or ventriculomegaly?
Ventriculomegaly, because I need to go to bed.
Ventriculomegaly, precise.
It's getting late in Australia.
No, this is a much simpler case. It's just 2 cases which are very simple, more for discussion, not so rare case like Rama. So maybe I could ask Vivek to see the first moving flip. Vivek Krishnan or Lokesh. It's an axial view of a 30-week pregnancy who came for the first time to us. So you can see that this ventricle looks normal. There is cerebellum which looks normal. It's an axial plane. This is a coronal plane.
So in the axial planes, you could see a midline cystic structure that's posterior to the seemingly looking structure. It looks like a CSP. Again, not a very clear, not a very happy with the CSP.
So the CSP is there, but it's
But posterior to that is cystic lesion, and there's a cystic lesion beyond, and there's a large hypoechoic area to the left.
Yeah.
which a completely cystic area to the left, it seems to be indenting the brain parenchyma inwards.
Any
Or
thoughts
is
at
it-
this
is it just-
moment of time? So we did also some color pictures. That was at the level of the circle of Willis, and that was circle of Willis in coronal section.
Chandra, I'm not getting it. You said it is easy and it's ventriculomegaly. Maybe it's an Indian joke.
Now can.
Okay, Vivek, I mean, I think Vivek knows the case, but at
No,
least.
no. I don't know the case. It's the other Vivek now. So this is a solid cystic. I think this is a mass lesion, and we can see intermittent vascularity within this bizarre sort of, and this is actually distorted.
So is it in the brain or is it outside the brain?
It is because circle of Willis, it's okay. So this is inside. It's
Vivek?
looks
I think the left hemisphere is displaced upwards by the cystic lesion, which is extra ventricular in my view. Maybe some connection with the ventricle, but it's extra ventricular. And at the end of the clip, top left, you see that probably the upper hemisphere is there and the lateral ventricle is not seen because it's squeezed. You see the roof of the lateral ventricle at the end of the clip. Yeah, there. So my guess is that might be a huge arachnoid cyst pushing up the lateral the hemisphere.
Lokesh, Ramamurthy, any comments? Let's just take a quick. Okay, so I think if anybody has any comments, otherwise I'll switch to the MRI.
Is there a sagittal sweep, sir? Is there a sag cut?
No, I don't have a sagittal sweep, only the axial and the coronal. Couldn't get a good.
Is it
You
one cyst
have-
or is it multilocular?
That's a good point. It's multiloculated.
Yeah, it is
It's multiloculated. But
There is
this is the
something that
MRI. I think
there is something that worries
So,
me in the
Dario-
ultrasound. If you can show, just go back 1 second to your axial, the upper left. Yes. And then here, if you can stop there. You said it is 30 weeks, yes?
30 weeks, yeah.
30 weeks. You see that the medial sulcation of the non-affected hemisphere, let's say like that, is quite different from expected for 30 weeks. Yes, the upper.
Actually, the
you see
Sylvian
two
fissure is
sulci.
close.
Now, but you see two sulci there in the medial aspect. Yes, that they are quite different, not the Sylvian, but two sulci there that they are quite different from expected for the surface sulci that you expect to 30 weeks. And that's why, independent of the nature of the lesion, I asked myself if the damage also didn't affect the cortical development. And I also have a question regarding the normality of the corpus callosum, even if I didn't see your sagittals and coronals yet.
Okay, I think there was a clue here. This is the middle cerebral artery, which is lifted up. And that is the MCA, which is getting lifted up here. That's the normal MCA, which is going right up along the sphenoid wing. And here, I think that's the real reason why we asked for an MRI, because here you can see the middle cerebral artery suggesting, and probably Dario was right. I don't know whether it was for the reason of the middle cerebral or just by the first picture, by the actual picture. So, Karina, we didn't really look at there was, I mean, like Gustavo said, you should look for the second abnormality, but really our focus was not on that Sylvian fissure. We were worried about this middle cerebral artery getting stripped off from the sphenoid bone here. And so we got an MRI done, and I think Dario was right. This was a suprasellar I mean, anybody wants to say from the MRI point of view? Any thoughts on the MR, which is? So it was an extracerebral lesion which was pushing up that portion of the hemisphere, and it was a suprasellar craniopharyngioma which was pushing up the entire brain. And the only idea of showing this was that sometimes these complex lesions we may need MR, but there are some subtle signs here. This really was the middle cerebral artery which was lifting up the whole brain, getting stripped off. Now, going by that and mourning Gustavo's talk on intracranial tumors, I added one more case because Simon made a statement that we don't see first trimester tumors so easily. I think Simon did, you probably said that. And so
Yes,
this is
I
a
did.
14-week pregnancy. This is a 14-week pregnancy. And Vivek Kashyap, do you want to?
We can see the ventricle, which is dilated by this mass lesion. And I think
It's
this
pretty
is
straightforward. I mean, it's just.
Yeah, so it is a.
No. So it does show vascularity, and this was a choroid plexus papilloma in 14 weeks. I just put it because Simon said that it's not, I didn't know it was uncommon, but because Simon said in the morning. So this is the third case, because just showing through the tumors, which Gustavo has not shown. And I'll just go through this quickly. This is a mild ventriculomegaly, 20 weeks. The corpus callosum was seen partially here. The cerebellum was corresponding to 17 weeks, and this was the sagittal view. So, any comments?
Ganglionic eminence cavitation.
Sorry?
Ganglionic eminence cavitations with
Yes. That's true. So just to refresh what you have seen in the morning, just probably checking on that. But the whole, the multitude of abnormalities that we were seeing here was the point of interest. And honestly, when I did this case, I didn't know, this is about 3 years back, and I didn't know much about ganglionic eminences at that time. And it was Dr. Rui who guided me for this. So, and it turned out to be a tubulonopathy because we had multiple findings. There was partial agenesis, corpus callosum, there was ventriculomegaly, small cerebellum, and a mix of cases, a mixture of all these findings. Now, just to finish the tumor part of it, this was a patient with this kind of mass. Just to finish the situation of cranial tumors. So this is just an orbital mass. It's a rare retinoblastoma, which is destroying the optic ophthalmic artery. Now, actually going to the next case, Lokesh, to you. This is absolutely straightforward case. It's just more of counseling that this is Dario's pet subject. So I'll ask you to comment. It's clear cut, absolutely.
Yeah, I cannot interpret the ultrasound with a
Oh, sorry,
pediatric
then
neurologist.
Vivek.
Okay, the Kashyap. Yeah, okay. So we have a large cystic mass lesion in the posterior cranial fossa, and we have the vermis which is rotated. So this is the first thing that has struck us. Then
So straightforward.
it's open.
You can give the diagnosis.
Okay, Dandy Walker.
Dandy Walker, yeah. So this is a Dandy Walker, and the only thing is counseling, because when we have a Dandy Walker, what should we do? I just want to there's more part of this case. So just from point of view of the audience, what do you counsel?
Yeah, I think Dandy
Should we
Walker-
terminate? Should we do what? Do the evaluation?
Yeah, I think the Dandy Walker outcomes are quite difficult because even ambulation might take up to 7-8 years, and the speech can be quite significantly affected. Some of them can have obstructive hydrocephalus requiring surgical interventions. We have had children after surgical intervention for obstructive hydrocephalus who are ambulant even at 2 to 3 years and going to regular school but requiring assistance in the school. So definitely there is some amount of neurological implication which varies from going to regular school with special assistance to somebody who is not able to go to regular school. So that's a varied
So you would ask to terminate?
Yeah, that's what we give this one
Vivek?
outcomes. This is the outcomes we
Vivek,
give the parents.
Krishnan?
For us, it's easy. We have a pediatric neurologist next door, so we just send them across. But yeah, roughly the same thing. It's very, very varied prognosis.
Professor Dario,
Well,
Daniela.
the short-term outcome, again, if you look at the questionable meta-analysis, is 50% intact outcome. But if you prolong the follow-up until adolescent life, it's a nightmare. So in the range of 70% of major, from ASD spectrum to major cognitive language always involved. I think the pediatric neurologist may confirm this data. And so actually the decision on termination is on the couple. So we just can mention the data. This is what we do in Europe. There has been some evidence that the amount of lobulation that you have left in the vermis may correlate with the outcome. So the more lobulation you have, relatively better is the outcome. So this may be looked at in those countries in which you do not have a legal limit for termination 22 as we do in Italy. So that's my comment. If there is no other comment on this, I would kindly ask you to go back to the orbital lesion. Yeah, and ask you, did you have an histology on that confirming the retinoblastoma?
Yes, we have a histology.
Because it's quite unusual because the retinoblastoma is a late onset lesion.
Yes,
We followed a few patients at high risk because they had themselves the mutation, and it's arising very late in pregnancy. So it's quite unusual for that to be a retinoblastoma.
So
And
we
if
had
I
the
could
same
ask you-
issues about. Sorry.
Sorry, if I could ask you to go back to the first semester case and after the first semester, the first case. So we start with the first semester. And to my knowledge, no cases of cerebral brain tumors have been reported in the first semester. So if this is a first semester tumor, it's worth putting it to print. But if you could go back to it.
The first trimester case.
Yeah, I just want to check that I define first semester, I'm coming back to the point in my talk, I define the first semester as ending after 13 weeks and 6 days. And when I look at this, I'm looking at the reference landmarks as to whether this is a BPD. This looks to me more than 13 weeks and 6 days. So if you look at your reference
It's
landmark.
actually 14 weeks.
It looks
It's
later.
14
It
weeks,
looks like,
4 days.
well, it looks like, yeah, it looks even later than that. So I don't think I would call this a first semester brain tumor. That does not look like a cranium of 13 weeks to me.
So
and if
Simon,
go
this is 14 weeks. This
14
14
weeks, is
weeks,
it?
4 days, but the tumor of this size would have taken a week or two to grow.
And it's an accurately dated pregnancy. And did you base the gestation calculation on the BPD because it's going to be enlarged with the tumor? I mean, it just doesn't look like that to me.
Yes, it's
Could I go
written
back?
there. It's the age. It's measured. It's 14 weeks, 4 days.
Yeah.
The gestational age is 14 weeks, 4 days. The size of
Okay.
the fetus. We did a
Okay.
first trimester termination for this baby. It was a 14-week, 4 days fetus.
Okay, but I still stand by the point I make. We call this the second trimester, not the first trimester.
No, yeah, that's true, Simon. But any tumor of this sort would have taken a week or two to grow. So I was just
Yeah.
from that point
Good
of
point.
view. Now,
Yeah, no,
I
good
think we
point.
are running out of time. So
One
this case is interesting because most of us will give the same counseling about termination and doing the till you come across this patient. This is a 29-year-old lady, low risk on NT scan. Last 2 slides. 19 weeks. No. This is the same, the second case, otherwise it won't get completed. So 19 weeks anomaly scan with a classical Dandy Walker malformation. And when we sat down to counsel, the mother said that that's not a problem. Even I have a Dandy Walker, and this is the mother's MRI. So just to show you that, not all Dandy Walkers will have a bad outcome, and we must be very careful because reportedly, of course, the husband may have had some reservations, but she was seeming to be absolutely normal, and she lived through her life with the Dandy Walker malformation.
Yeah,
So
well
she's-
done, Chandra.
She's got
Nice
a
case.
child now, a fetus with Dandy Walker.
Yeah, I had 2 cases recently. One was a very nice and sweet woman, and she was worried because we found the Dandy Walker in the 17 weeks, and she brought her MRI and confirmed same mirrors yours, and she was very nice woman. And a second case in which again there was a woman who came, a couple, and she admitted having a Dandy Walker malformation, was very nasty and aggressive woman. So maybe something.
Aren't all women that way?
Something could have been happened over there.
Now, as far as advising termination is concerned, never advise termination. We explain them the possibilities of pros and cons. It is not our decision, it is their decision. So never ever advise a termination. You terminate the pregnancy, because we can't tell any woman to terminate any pregnancy. So it's their wish, but our point is we tell them that if you continue, these are the points. If you discontinue, it's your decision. So it has to be this way. So never advise termination to any female, because it can be medical legally, it can create a problem to you any day. Thank you very much.
Thank you so much. It was a wonderful discussion. Thank you, Dr. Chandravila sir and Ramamurthy sir, for moderating such a nice panel.